And here we are at part 2, and on this part we're going to be looking at immune hemolytic anemia, so immune causes of hemolytic anemia. This is quite a long section, and I'm expecting that it will take about 30 minutes. So we're going to have a look at differentiating some immune hemolytic anemias by their clinical and laboratory findings, including diagnostic tests. You don't need to have an in-depth knowledge of these conditions because we revisit them in transfusion science next semester, but you do need to be able to classify them and differentiate them from other causes of anemia, and you need to be able to give at least one example of each type of immune hemolytic anemia. So when we're looking at immune hemolytic anemias, they are defined as a shortened red cell survival mediated through the immune response, particularly antibody mediated, so the humoral immunity. So they are further classified according to their specific etiology, so whether they are antibody mediated or drug related, and they're yet further divided into autoimmune causes or alloimmune causes. So autoimmune causes, so this means when the body has something's gone wrong with the immune system and the body has developed antibodies against itself, so antibodies against its own red cells. Alloimmune hemolytic anemias, on the other hand, are due to normal immune response where the immune system has detected different cells, different antigens coming into the body and has produced antibodies against those different antigens, and they just happen to be on red cells, and so the red cells are destroyed. In autoimmune hemolytic anemias, the direct antiglobulin test is usually strongly positive for either IgG or complement, whereas in alloimmune and drug-induced hemolytic anemias there is variability depending on the blood group of the antibody causing the hemolysis or the mechanism of drug reaction. So the direct antiglobulin test is a test that we rely on a lot, particularly in transfusion science, but it's a very useful test because it immediately tells us whether or not we have an immune cause to whatever is happening. So let's just have a bit of a revision about how immune-mediated hemolysis happens. So the process involves both the adaptive and innate immune system, so you need to review your immunology and anatomy and physiology notes about how the immune systems relate to each other and also the different classes of immunoglobulin or antibodies. So what happens in a nutshell is that activated, stimulated B lymphocytes divide and mature into plasma cells that produce specific immunoglobulin, and so this is released into the plasma. So the lymphocytes themselves, the plasma cells, stay within the lymph nodes, but the antibody that they produce is a water-soluble protein, and it travels around the body in the plasma. So the immunoglobulins of interest to us when we're looking at immune hemolytic anemias are the IgG and IgM classes, and so they have been raised against a specific stimulant or antigen which is actually present on the red cells, and hence that's why the red cells are being destroyed. So the antibody locks onto the antigen, and one of two processes takes place depending on the class of the antibody. So remember, this antigen is on the red cells. So it's usually some form of a protein or receptor that is on the surface of the red cell. So if the antibody is IgM class, they are actually large enough to lock on to the antigenic sites of more than one red cell. And so here's our IgM antibodies, and they are able to agglutinate and bring together more than one red cell. And so this process activates and fixes complement on the surface of the red cells, and then we get intravascular lysis of those cells. IgG class antibody, on the other hand, are too small to agglutinate the red cells directly, and so they lock on to the antigenic sites of their individual cells. And we say that this is what these cells have been sensitized by the IgG antibody. So this attachment of the IgG antibody to the red cell membrane is able to activate complement, but usually only to the cleavage of the C3 molecule. So we end up with C3b on the cell membrane. And so as these cells pass through the spleen, the sensitised cells, then the macrophages within the spleen, the fixed macrophages in the spleen, have an Fc gamma receptor which recognises the IgG antibody on the red cell surface, and also there is a C3 receptor that recognises the C3b that is attached to the cell surface, and so the phagocytes will actually phagocytose these cells. If there are only a few antibody molecules attached to the cell membrane, the macrophages may be able to remove just that part of the cell membrane, so that's what we call pitting, if you remember, and then what happens then is that the cell loses its lovely biconcave disc shape and becomes a spherocyte. It becomes a sphere. And so that's what happens in immune-mediated hemolytic anemia in a nutshell. So usually if we have an IgG antibody, I guess that's what I should point out, if we have an IgG antibody that has been produced by the B lymphocytes, then we get sensitised red cells that are removed from the circulation by the spleen, which is extravascular hemolysis. If we have an IgM antibody that is produced, then we can have direct agglutination of the red cells with complement activation, and we can get intravascular hemolysis. Okay, so that's, again, we've got that intravascular or extravascular hemolysis depending on the class of the antibody. So some people may have already met the antiglobulin test or the Coombs test, and this is an in vitro test that detects sensitised erythrocytes. And so we call it, what we're showing here is what we call the direct antiglobulin test. So these are cells that have already been sensitised within the body that are being detected in the test tube. So they're sensitised in vivo and we are detecting them in vitro. And so, as I said before, the red cells have been sensitised by IgG, and so the IgG is not able to directly agglutinate the cells, but it marks them for phagocytosis. It opsonises the cells, marks them for phagocytosis, and they are removed by the fixed macrophages in the spleen. So we can see basically what the antiglobulin test does is that we use this antiglobulin reagent or Coombs reagent, and the antiglobulin reagent is it's an anti-human globulin, so it is an anti-antibody reagent, if you like. And the way they make it is that plasma is, or IgG immunoglobulin is injected into a mammal. It's usually, it could be a rabbit, it could be a horse, it could be a mouse, depending on what it's being used for, or depending on what they want it for. And so what happens is that the mammal, of course, because we are introducing something foreign to them, raises an antibody to that immunoglobulin, and then harvesting of the plasma from that mammal and purifying it gives us this anti-human globulin reagent or Coombs reagent, which is an anti-IgG reagent. And so it allows us to then, when we add that to our sensitised red cells, it actually links up, it attaches to the Fc portion of the antibody that is attached to the red cell membrane, and it actually allows us to visualise that agglutination. And so that sort of grainy looking sandy red stuff in the tube there is agglutinated red cells, and on top you have a tube that just has the red cells with some saline in it, so you can see that it is nice and smooth and red, and it's not sandy and bumpy as is the tube below it. So that is the direct antiglobulin test, or the Coombs test, and it's a very useful test, very quick and easy test to do, and you'll be doing it in the prac this week. So we're going to start by looking at autoimmune hemolytic anemias. So these are hemolytic anemias that for some reason the immune system has developed autoantibodies to the person themselves. So this is something has happened, there's a defect with the immune system, and it has raised antibodies that are attacking the person's own tissues or cells. Now these hemolytic anemias can be classified as being either warm or cold because they react at different temperatures. So it is based on the optimal reaction temperature of the antibodies involved. So when we look at warm autoimmune hemolytic anemias, these react best at 37 degrees, and they are caused by IgG class antibodies. So patient red cells sensitised by the antibody are removed by the reticular endothelial system because they are IgG class, and so we end up with extravascular hemolysis. So that's why it's really important to understand that it is IgG antibodies that cause warm autoimmune hemolytic anemia, and you just have to think that IgG react best at 37. They react best at body temperature. There is no particular population more likely to develop warm autoimmune hemolytic anemia, but it has been associated with autoimmune disorders and also some medications. So if autoimmune disorders such as lupus or multiple sclerosis, those sorts of conditions where we already have a defect in the immune system, so I guess if you've got one defect it's easy enough to for another defect to develop. So cold autoimmune hemolytic anemias are also known as cold agglutinin disease, or CAD, and they're called cold agglutinin disease because of the optimal reaction temperature of the antibodies. So these are IgM class antibodies, and they have a thermal amplitude, or their best temperature for reaction is between 2 and 4 degrees Celsius, but they do have a thermal amplitude of up to 30 degrees Celsius. And remember that IgM class antibodies can activate complement, and so they are able to produce immediate intravascular lysis. We can also get extravascular hemolysis as well, and this can happen because you think, oh, you know, body temperature is 37, but when in the winter in Tasmania, if you look at, in your extremities, they get quite cold, don't they? Your fingers and toes can get very cold, your nose and your ears can get very cold, and so they get down to much lower than 37 degrees. And so the IgM class antibodies are able to cause agglutination within the vasculature, or sometimes they will bind to the red cells in those peripheral areas, and then as the blood comes back to the centre of the body and gets warmer, the IgM class antibodies actually disassociate, but they leave the complement behind on the cells, and these cells can be removed as the cells as the blood goes through the spleen. So we can get mainly intravascular, but there is an extravascular component as well. We can see that we can get primary autoimmune hemolytic anemia, and the majority of these are idiopathic. They just happen, nobody knows why. But about 40% of autoimmune hemolytic anemias are secondary to some other disorder. And again, we often see that these disorders are to do with immune conditions, or drugs that interact with the immune system, or lymphoproliferative disorders. So these are disorders that you'll learn about in the second half of semester, and as makes sense, the lymphocytes are responsible for producing antibodies. So if you have lymphoproliferative disorders, then you're more likely to have abnormalities in the immune system. And also they can be secondary to infections as well. So these can be viral infections and also bacterial infections. So when we look at the clinical signs and symptoms of autoimmune hemolytic anemias, with warm autoimmune hemolytic anemias, they tend to be the symptoms of the symptoms of anemia. And if we just go back to the slide before, what I did neglect to mention, you can see down the bottom there, is that we can either have acute hemolytic anemias, autoimmune hemolytic anemias, or chronic. Now, the acute ones tend to be warm autoimmune hemolytic anemias, and the chronic ones tend to be the cold agglutinin disease. So you can see that the acute, you get this sudden lysis of the red cells, even though it's usually self-limiting, but it's a sudden anemia, whereas the chronic one is much more slowly in its development, much more slow in its development. That doesn't sound, that grammar is very bad. So back to clinical signs and symptoms. So we do, with warm autoimmune hemolytic anemias, the clinical signs and symptoms tend to be those associated with anemia, because the anemia happens very suddenly. So we have weakness and tiredness, and because, remember, it's extravascular hemolysis, so we can get splenomegaly and jaundice. Cold agglutinin disease, on the other hand, tends to come along quite slowly, because it tends to be more chronic, and we get numbness and tingling and pain and cyanosis in the extremities. So why do you think that might be happening? And have a think about that, and if you can't think about why it might be happening, and it's something to do with the fact that they are IgM antibodies and what those IgM antibodies are able to do. And we also get hematuria and hemoglobinuria, which of course are hallmarks of intravascular hemolysis. And you can see here, there's an image there of somebody who has got peripheral cyanosis, and so this is where we get the purpleness in the fingers. You can see it in your toes. Some people get quite purple noses, and earlobes get quite purple as well. One particular condition that you do need to know about, and that's cold agglutinin disease. And again, this is due to the IgM antibody. So we get intravascular agglutination and hemolysis, and it can be idiopathic, but the reason that you need to know about it is because it can be caused secondary to infections. And so these infections include a mycoplasma infection, so mycoplasma pneumonia, which is a bacterial infection and causes quite a nasty pneumonia. But also we can see agglutination of the red cells on the blood films caused by HIV virus and also Epstein-Barr virus. So the Epstein-Barr virus, of course, causes glandular fever. And the reason that you need to know about cold agglutinin disease is because we can end up with what we call nonsense FBC results. And so we end up with a red cell that's too low, red cell count that's too low for the hemoglobin. They just don't match. Usually, if anything, sometimes your hemoglobin is lower. It doesn't seem to match the red cell count. The hemoglobin seems too low for the red cells, but not this way around. This is really weird. And we can get a falsely very increased MCV, MCH and MCHC, and a false low hematocrit. And this is all being caused by the fact that we are getting intravascular agglutination of the red cells, so they're not being hemolyzed, but they're being agglutinated. And we can actually see this in the blood film, because once the blood is withdrawn from the patient, of course the blood cools. So it cools to room temperature, and of course in Tasmania, depending on if you're in an air-conditioned environment, then that room temperature can get down to below 20 degrees. And so if we have an IgM antibody with a thermal amplitude of up to 30 degrees, then that antibody is going to be activated, and it is going to lock on to its antigens on the red cells, and we see this as agglutination. And so this is what it looks like. So you can see these big clumps of red cells, and as these go through the analyzer, they are counted as one cell. So we've got, lots of these giant cells going through. So you can understand that the analyzer would not count them as individual red cells, it counts them as one cell. And so the red cell count is low, the MCV is really, really high, but the haemoglobin still makes sense because the way that the haemoglobin is measured, as you know from doing it manually, is that we lyse the red cells, don't we? And so it doesn't matter if they're agglutinated because they're going to be lysed to release the haemoglobin so that we can measure it. And so that's why we get a haemoglobin that seems to be too high for the red cell count. So what do we do to prevent this? How do we resolve it? Well, what you do is you put the sample in the water bath. You warm it up to 37 degrees and then quickly put it through the analyzer again, and you will find that because it is higher than the thermal amplitude for the antibody, it disassociates from the red cells, and we end up with a normal red cell count, and normal MCV, normal MCH and MCHC and hematocrit as well. So be on the lookout for these agglutinated red cells, particularly in people who have glandular fever. Okay, so now we're going to go on and have a look at the alloimmune hemolytic anemias, and so these are the ones where the body is reacting more normally and it is producing antibodies against antigens that are foreign to the body. And so in this case, the antigens again are on the erythrocytes because they're carrying foreign membrane or blood group antigens. And so you will spend a whole semester, next semester, learning about these blood group antigens and the sorts of conditions that they can cause, how we detect these conditions and how they're treated. So alloimmune hemolytic anemias, the immune system has produced antibody against some foreign antigens, and so it then protects the body from these foreign red cells. So if the antibody is already present in the plasma in significant concentrations, and we introduce blood that has that particular antigen on it, then the result is an immediate hemolytic transfusion reaction. And the worst case scenario is with ABO blood group mismatch, because these ABO antibodies are actually IgM class. So other blood group antibodies are IgG class, but the ABO blood group antibodies are IgM class. And the thing with these ABO blood groups is that we already have antibodies against the antigens that we don't possess. And so people who are blood group A have A antigen on their red cells, people who are blood group B have B antigen, people who are blood group AB have both A and B antigen, and people who are blood group O have no A or B antigen on their red cells. So I am blood group O, and because I don't have any A or B antigen on my red cells, I naturally have anti-A antibody and anti-B antibody. Even though I've never been transfused, I still have those antibodies there. They're not really sure why this happens. They're called naturally occurring antibodies, and they happen with some of our blood group systems, but not many. And the ABO one is the most important one. So if I was transfused with group A red cells, then I would have an immediate hemolytic transfusion reaction, and if that transfusion was not stopped, I could die, because this sudden hemolysis of all of these red cells would overwhelm my system and I would die. So other blood group antibodies are IgG class, and so we know with IgG antibodies they are too small to directly agglutinate red cells intravascularly, but they are able to sensitise the red cells, which are then removed by the spleen, so we get extravascular hemolysis. So we can because IgG class antibodies don't tend to hang around in high concentrations in the blood, their concentrations tend to wane, then we get, if we are given blood that has antigens on it that we would produce an IgG class antibody to, we get what's called a delayed hemolytic transfusion reaction. And so this is because, as you remember from your immunology, if the immune system is challenged, it takes a little while for it to respond to that challenge, and if it's challenged a second time, it's faster to respond, but it can still take up to a week to respond, depending on the blood group antigen and antibody that are being stimulated. So we can get a blood group mismatch, so we can get immediate intravascular hemolytic reaction, which is very serious and very severe, or we can get what we call a delayed hemolytic transfusion reaction that's caused by IgG class antibodies. And the other thing that you need to know about is a condition called hemolytic disease of the fetus and newborn, HDFN. And what happens here is we have a transplacental bleed sometime during the pregnancy. So here is our placenta here. Here's our baby in its placenta. Here is our chorionic villi here, and here is the uterus and the cervix at the bottom here. And so the chorionic villi is where the maternal blood mingles with the fetal blood. It doesn't actually directly mingle, but this is where we get diffusion and osmosis between the mother and the baby. Sometimes what can happen is that we can have a tear in the uterine wall, so we can have a tear here around where the chorionic villi are, and we can actually have fetal blood entering the mother's system. This most commonly happens at birth, and you can understand why, because of course the amniotic sac is actually tearing away from the wall of the uterus, and so the placenta is being torn here, and fetal blood can enter the maternal circulation. And so if that happens and the baby's blood cells have inherited antigen from the father that the mother doesn't possess, then of course the mother's immune system is going to produce antibodies to that antigen. And so it may not affect the first baby, but it could very well affect the second baby. And so we can then, because the mother will have antibodies to that antigen in the system, and then if she's pregnant with another baby who also inherits those antigens from the father, those IgG class antibodies are small enough to cross the placenta and actually attach to the fetal red cells and remove them, have them removed by the fetal spleen. And we can end up with this poor little baby who ends up with a really severe hemolytic anemia that results in congestive cardiac failure and a condition called hydrops fetalis, which is very nasty indeed. Once the baby is born, we can end up with neonatal jaundice, and the jaundice can be so high that, because remember it's extravascular hemolysis, that it can actually affect the brain tissue, and the baby can have irreversible brain damage if it survives. So there's hemolytic disease of the fetus newborn can result in the death of the fetus or the newborn baby, which is very, very sad. And so in a normal neonate, you can see that we do have a macrocytosis. So let me see, I'm just looking through my notes here to see what the normal MCV for a baby is. And I can't see it, but they are usually larger than adult cells. So you can have a look in your Pratt method book, and at the end there you'll see that you've got the pediatric reference intervals. But you can see there it is normal to have larger red cells. It is in fact normal to have up to 10 nucleated red cells per 100 white cells, and this little one here, that is a nucleated red cell. And it is also common to see some reticulocytosis there, so polychromasia, and also common to see some spherocytes as well, so that's all quite normal. Can anyone remember what this inclusion body is in this red cell? And that's just showing us that the spleen is less mature than we would expect it to be. On the right-hand side here we have a picture of a neonate who has hemolytic disease of the fetus newborn. And so we have a macrocytic anemia. You can see there are lots of nucleated red cells there. There's lots of polychromasia, and there are lots of spherocytes. And so we can get hemolytic disease of the fetus newborn with other blood groups. The one that you would most likely have heard about would be RHD. RHD positive babies being born to RHD negative mothers, but we can also get it with other blood groups as well. So we can see, and what do I want to say here? So keeping in mind that most of these autoimmune conditions, all of them have an antibody component to them, and so we can actually detect the antibody or the complement fractions that they have activated on the surface of the red cells, and we can do that by using the direct antiglobulin test. So that's a really quick and easy test that we can do that is able to differentiate between immune causes of hemolytic anemia and non-immune causes of hemolytic anemia. So now we're going to finish up looking at hemolytic anemias that are drug related. And so what happens here is that we have an interaction between the drugs and the immune system, and sometimes an antibody is raised. Well, an antibody is raised, but sometimes we can't actually identify what that antibody is. So we have, they're usually not that bad, the anemias that are caused. Usually, they're usually fairly mild, but severe cases have been known. And really the best way to treat these hemolytic anemias is to withdraw the drug, because usually once the drug is withdrawn, the hemolysis resolves. So the antibody production to the drug or the drug complex happens by a number of mechanisms, and they include, as you can see here, the drug-induced immune complex. It's also known as the innocent bystander mechanism, where an anti-drug antibody drug complex forms. So here's our drug, the antibody attacks it, so we've got this complex which is then adsorbed onto the erythrocyte membrane, and that stimulates complement fixation and red cell destruction. So that's the innocent bystander. So, you know, these complexes attached to the surface of the red cell activate complement and the red cells are destroyed. And the next one is what we call drug adsorption. So the drug actually adheres to the cell membrane first, and the drug on its own is not large enough to be able to stimulate the immune system. So the antigens that stimulate the immune system have to be a certain size. But once they have been adsorbed onto the surface of the red cells, they are now large enough for the immune system to see them, if you like. And so the antibodies are produced against the drug, and they attach to the red cells, and the red cells are destroyed, usually by extravascular hemolysis, as you can see there. And then we have autoantibody mediated hemolysis, and in this we have the fact that the drugs actually stimulate antibodies to be produced against erythrocytes rather than the erythrocyte drug complexes, so we end up with an autoantibody. And then finally we can have what we know as a non-immune mechanism, and so this is a really strange mechanism where the drug actually modifies the red cell membrane, and so it allows for protein absorption and membrane modification, and then non-immune components of the immune system, if you like, which sounds a bit weird. So we get complement is adsorbed onto the erythrocyte, and so we can actually get adsorption of IgG as well, but there's no actual, it's not an immune thing, it's an adsorption thing, but it's still enough for the macrophages to remove the cells. So here is a summary of the drug-related autoantibody formation. So we get a positive direct antiglobulin test in each of these cases, but when we go and try and identify the antibody that's causing the positive DAT, so we are able to actually remove the antibody off the red cells and identify it in a process known as elution. Often we are not able to identify it. So if we've got hemolytic disease of the fetus newborn, we are able to elute the maternal antibody off those red cells and identify it. And when we have autoantibodies, we are able to elute them off and identify them as well. And when we have drug-related autoantibody formation, we can also elute the antibody off. And sometimes we're able to identify it and sometimes we're not. With this membrane modification, we are not able to identify it. And you can see there the sorts of drugs that are likely to cause this drug-related autoantibody formation, and many of them are antibiotics. Okay, so we're right at the end of the second part. I did say this was a long recording, but we're back with our case study now. And so if we have a look at our questions, yes, the clinical history does relate to the full blood count. The blood film is what we would describe as being, it is a macrocytic blood film, but it's macrocytic because of the reticulocytes. And so we have polychromasia there, probably at least 2+ polychromasia. We have a lot of spherocytes there, so probably 3+ spherocytes. And we've got, and so that would give us an isocytosis of about 2 to 3+ as well. That is a blood film that very much matches a hemolytic anemia. So we've got the bone marrow is trying to produce extra cells, and that's why we're seeing the reticulocytes. We've got lots of spherocytes there. We don't have schistocytes, so this is probably extravascular hemolysis. If it's extravascular hemolysis, what else would we expect to be increased? So we would expect to have our bilirubin increased as well there. And also we would, as soon as we see the spherocytes there, particularly with that clinical history, we would be doing a direct antiglobulin test. And if what we were thinking was true, and that this woman had actually developed antibodies to red cells that had been transfused, then she has an alloimmune hemolytic anemia. It's a transfusion reaction, and 3 days later it's what we would call a delayed hemolytic transfusion reaction. And what was I saying there? So you would expect, there's a fair bit of trauma going on here, so you would expect an increased white cell count and an increased platelet count as well. So the first further test that we would be doing is a direct antiglobulin test to see if we can make sense of those spherocytes. Okay, there's a couple of review questions for you to answer in your own time, and if you have any trouble with those questions, as usual, please put comments up on the week 3 discussion board. And that is the end of this.